I started to think about my history, my career. How did I get here today? How did I get here today? And I walked, actually I live 2 blocks from here. And I'm going to try to give you a little bit of history about me, because maybe that says something about how one becomes an advocate if you're a researcher, if you have that in mind. It was never my intention, but I think it just happened, and I'm going to try to show you how it did happen. I want you to read this quote. I'm going to come back to it at the end of my talk, but think about it for a second. It's a very powerful quote that came from one of the many focus groups we've done over the years. So, how did I get here? Well, I walked. Actually, I'm very fortunate. I live 2 blocks from here, and so are my offices 2 blocks from here. It's great being in New York City. But I want you to give you a feel about who am I and where did I come from. My first stop in 1972, I became a faculty member at Columbia University, College of Physicians and Surgeons. They dropped that recently, PNS. And my appointments were in neurology and psychiatry, and my division was in neuroscience. I would not realize until many years later that this was a very rich research environment, as is almost any teaching hospital medical school. It's an advantage to anyone who's in that environment. And I was given my first lab, and it was the lab of Houston Merritt, who discovered Dilantin. And it really did look like that. It was all mahogany cabinets and little cubby holes, and it looked like something out of a Frankenstein movie. Nonetheless, it was my lab. I was a young guy, whatever, and I was given this space. And adjoining that space was a little room that no one told me about, which is where they did topectomies and took out parts of your frontal cortex. And then another room was where they did transorbital lobotomies. So I was in a historic location, and nonetheless, I appreciated it. I was a member of a group of neuroscientists who were lipid chemists. Most chemists are protein chemists. So here I was in this very strange atmosphere where there were neurochemists who worked on lipids, proteins too, but worked on lipids. And little did I know that I would become well known because of my work on lipids, and specifically glycosphingolipids. And I was a neurobiologist by training. Trust me, I wasn't ready for this. So, but I was very fortunate to have in my group people who raised antibodies to lipids, which are not very antigenic. And I had available to me antibodies to these lipids. And this was the paper that launched my career in science in 1976. And it really did. It secured for me almost 10 years of NIH funding and NSF funding, and made doing research a joy, as it always is when you have money. And I would become increasingly involved in studying these lipid compounds, not just the antibodies against them, but also the compounds themselves. And it's very interesting. There aren't that many lipid chemists in the world, but I was amidst several of them, including my chief, who was the man who discovered the structure of serotonin. He was an American Cancer Society professor. And he would drag me to meetings where I would be in Tower B at Rockefeller, and I'd sit at a table, and there was like one Nobel laureate at every table. I learned that they put on their pants or dress like everyone else. This is one of the more important papers I did, which is in the Journal of Neurochemistry, was looking at how gangliosides affect the pumps, the sodium-potassium pumps across the membrane. Back then, everyone thought lipids were like coat hangers, where all the proteins just hang in there. But they really have a function that goes far beyond that. And then I learned very early on that you should have a disease. If you do basic science, you have to have a disease to hang your hat on to make it relevant. So I became very interested in stroke ischemia, and I developed a model for middle cerebral artery ischemia, and was able to show that gangliosides themselves would prevent a lot of the dysfunction or loss of function that occurred after stroke. So this was further launched my career. So I went from studying antibodies to studying the compounds themselves, lipids. We had in my lab, we had purified lipids. Not many people had that. So I had lipids in quantities enough that allowed me to treat animals. There was a pharmaceutical firm in Italy called Fidia, just outside of Venice, which was great. And they cornered the bovine brain market in the world. And by doing that, they were able to extract huge amounts of GM1 ganglioside, monocyl ganglioside, and bring it to production for clinical trials. So I was part of their effort to establish labs in Italy, which was great, and especially because it was about 2 hours outside of Venice, to which I'd been God knows, 50 times. So, in that process of being really a basic researcher, scientist at Columbia, I had an opportunity to see the world. I got invited, literally, to go around the world at least once a year for 10 years, and in one of those years, 3 times. Had science that people were interested in, and as I think about it now, how did I get here as a advocate? I always had great slides. I used to take negative slides, and I go into a light box and literally hand color them. Because I knew that if I had a colored slide versus like just a regular old slide, people paid more attention. And if you're going through heavy topics or you're talking about glycosphingolipid, whatever, you needed every piece of armature you could get to communicate and to bring the people in. I was also invited behind the Iron Curtain any number of times. I would fly into Berlin on the white knuckle flights on Pan American because you had to stay in a flight path with 2 MiG jets on your wings. Land, go through Checkpoint Charlie, and go to Magdeburg. Some of you probably don't know what that city's all about, and try to help people set up labs there. I was invited to Moscow and Leningrad when Gorbachev was in power. My first visit, I went with Nobel laureate Levi Montalcini, who just won for the Nobel Prize in Nerve Growth Factor. Always in January, was 35 below. And it was great sharing information, of course, internationally, it always is. It was also the place where I first found out where my roots were. I happened to be Ukrainian. But when my grandfather, I would ask my grandmother, where did I come from? They would always say, the old country. And the reason they said that was that there was no longer a Russia, it was the Soviet Union. And both my grandfathers actually went AWOL for the Bolshevik army. Nonetheless, when my first lecture in Moscow, I finished, and then all of a sudden this group of about 50 scientists rushed up to me and said, "You're one of us, you're one of us." I said, "This is it, I'm lost. I'm going to be kept in Russia from now on." Anyhow, I learned my roots, and in fact, I've given several webinars to physicians in Ukraine in the last couple of years, which is really rewarding, even though their challenges are considerable. So you too can go around the world. Now here are 4 creatures on this, 5 actually, on this slide. And I mention this because I, at Columbia, was head of the Animal Safety Committee, basically the IRB for animals. And we raised antibodies in rabbits. My primary animal of interest was gerbils at a point. We had lions. Why do people have lions? Because they have arthritis. And then there were the monkeys, okay? And I was trained by some very famous neurosurgeons how to do surgery on the brain, because I did a lot of electrode implants. And does anyone know what's in the left quadrant there? So this is an aplysia. This is a snail, sea snail. So Columbia at one point decided they needed a Nobel laureate, so they put all their money on Eric Kandel. And Eric Kandel made extraordinary advances in studying the nervous system and neurons in this creature, the aplysia. So I was responsible for watching over the IRB of these little critters. I could write a book about this. This is my path toward being an advocate. So in 1995, I decided I was going to leave Columbia. I had been there for 25 years on paper, and I was not yet 50. And molecular biology was coming into play. You could just see it. And to this day, I don't understand what Mendel did. So I decided I shouldn't be in this domain anymore. And I was still a young man, relatively, and I said, there are other things to do. So I went to Phoenix, Arizona, and I did some work in the Mayo Clinic on spinal injury and pain. And then I became involved for the first time in HIV/AIDS at AIDS Project Arizona. And I handled the kind of pharmacy for these naturopathic whatever substances that were being used in lieu of a lack of any treatment for HIV. This is like 1994. And then I got to know naturopathic physicians. Bastyr University had a big university in Tempe, and we've become very attuned to their ways of teaching, their modalities of teaching and working on the body to make it heal. So I went to a hospital in Phoenix and said, hey, can you give me an exam room where I can put together a couple of allopathic, regular MDs, and naturopathic physicians so they can work on this population who at that time was suffering terribly from peripheral neuropathy. Sure, give us $1, I'll give you a whole suite. Not bad, right? So we started seeing patients, and most of them had peripheral neuropathy, and their mothers were driving them to the clinic. And then in a month or 2, they were driving to the clinic, and this is a good sign. They're becoming functional. So working together, these two medical modalities of treatment were really very effective. And then I had an opportunity to become an executive director. I regret that in many ways, but don't ever become an executive director unless you want to have headaches. Nonetheless, I became executive director of a place called Home. A place called Home did congregate housing for the homeless with HIV. So this is my coming to contact with the HIV epidemic. And this agency was begun by a priest who would go out to parishes in the Phoenix area, raise money, and purchase homes and rehab them. So I would come on board, and I learned how to extract money from HUD-HOPWA. And so we rehabbed about 6 homes, prepared them for patients who were mentally ill with HIV, homeless, and they had a manager in the home, and it was amazing, amazing. You could buy a home with HUD money, and you had to rehab it. So you pick up the phone, call Del Webb, we need a roof. They would bring roofing materials. We need a floor. People would bring tiles. We need the house painted. Make-A-Wish Foundation would come. 20 people on a bus on one Saturday, it's done. It was amazing. In fact, the homes were so beautiful, we had to kind of tone them down because they looked too good. And they all had a pool in the backyard. So that was my experience in Phoenix, and then I got tired of not seeing many people. Phoenix, the Southwest, is gorgeous, very hot, and you don't see people unless you go to a mall. So I decided I had to come back to New York, which is really my heart was. So upon coming back to New York, and this is how I'm getting closer and closer, I think, to being an advocate, I became the executive director of Pride Senior Network. Pride Senior Network was an agency founded by 2 older women who were lesbians and gerontologists. And they had worked on this for years, and they hired me to be their first ED. I was funded by the New York Foundation, the oldest charity in the USA. And in that process, I was trained by that charity how to be an executive director, how to get money, how to keep your books, whatever, et cetera. Every month, they would bring someone in, the best of the best in the world, training you how to be a good caregiver or caretaker of a charity on the 46th floor of the Empire State Building. So after 3 years, I had my successes. I developed a newspaper for older adults, older LGBT seniors, and I raised money. I decided to do an auction on Fire Island. So I got dresses from Gucci and Oscar de la Renta and clothing from whoever, and I put them on the residents in Fire Island who lived there, who owned property, which were wealthy people. And we auctioned the clothes off after I got them drunk. And made a lot of money the first year. And then the second year, one of my board members brought the entire cast of Sex and the City, the 3 women. They came. We made even more money. So I learned how to make money, always a tough to go. But nonetheless, I was now working not so much in the lab, but out there in reality. Then I later would leave that job, and then I became, in 2002, ACRIA, the AIDS Community Research Initiative of America, had a job opening. They wanted someone to begin research on older adults with HIV. So I said, okay, I knew the data. The data looked like it was going to progress, and the population was going to increase over time. This is 2002. So I came on board. My first job was to supervise their clinical trials. I had 3 physicians, 1 record keeper, and 1 recruiter. So we had brought about, 14 drugs to market in my period of 5 years supervising. A great experience until a drug goes to the market and the IND folks and FDA want to visit you. But we passed the flying colors. Later on, I would begin to focus on the older adults research, and I would become a member of the American Academy of HIV Medicine with the American Geriatrics Society, and my colleague here, Dick Havlick, to help develop clinical guides for managing the health of older adults with HIV. And that would have a direct effect on the next thing here is I just launched the National Resource Center on HIV&Aging, and much of the clinical data, the clinical guides come from that effort. And I'm a member of the Einstein-Rockefeller-Hunter-CFAR, which is kind of like that rich research environment that I was so accustomed to when I was at Columbia. So, why is it that I'm a good an advocate? I think one of them is I can communicate, and I have good slides. I told you I had good slides. So, and I also learned that when I give testimony before a Senate, a House of Representatives, be it local, federal, whatever, they don't care about information that doesn't pass the eyeball test. If you can't look at it and you can't convince that person what that's about, pack your bags and go home. They don't want to hear about a polynomial, whatever, blah, 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 equation. They don't want to know about factor analysis. They don't want to know about those fancy statistical methods, which we all embrace. They want to know what is the bottom line. So here's a good example. Today, ART is available to universally in this country. There are 1.2 million people living with HIV. If we took ART away, we'd be down to 2.2 million people living, and we would have lost 2 million people to death. That's a convincing piece of information. Turn it on its head. Here is the number of people, percent of people living with HIV over the age of 50 in the USA. You do not have to do a t-test on this. You give it an eyeball test. It's very clear what's going on here. The number of people with HIV over 50 keeps increasing every single year, progressively. Here's another one. I hate to use text on slides. People really don't like to read, by the way. And here's a simple one. Older adults are the majority of people living with HIV in the USA. I can't say it enough. We finally crossed that 50% mark. You'd think that people with HIV who are older was like some minority in the population. They're not. They're a majority. They're a majority, okay? I can't say it enough times. They are the largest part of this population, and we need to pay more attention to them. I think we spend less time because of ageism. Here's another one. Very little has been done on prevention in the older adult. And this shows, again, national data, those diagnosed with HIV in red, and those who have a dual diagnosis also with AIDS. It's very clear that as you get older, the chance of you being diagnosed with AIDS increases. It means that the system failed you. You escape testing. I think in New York City, 72% of all new diagnoses over age 50 occur in the ER. And here's another one. These are simple numbers, but important. 6,513 new diagnoses over the age of 50 in the USA in 2017. That's a lot of people. 6,500 people who are older adults got infected. As many communities are trying to, end the AIDS epidemic by 2020, 25, you can't do it until you pay attention to this number. You cannot ignore the older adult. So as I said, ending the epidemic requires us to focus on the older adult. The CDC, NIH has never given any substantial funds for prevention for HIV infection in this population. Never. So my first study, 2003, I guess it was, I recruited 150 people in New York City, not too hard to do, older adults, and we looked at their social networks. Now, back then, there was no Facebook, so people didn't really understand what social networks were unless you were a sociologist. So my mentor, Marge Cantor, who was an emerita, she was the godmother of social networks and caregiving. She helped direct the study, and what we found out was, yes, people with HIV had people in their social networks. But the question is not how many people are there, but who is functional. When you need help, will they come to your side? And what we found, just to simplify this, was that, yes, they had parents, but the parents would likely be dead by the time they got to meeting those caregivers. Children, some, but go down the list. The only people who hung in there with them were friends, which is great, except the friends also had HIV. So one was building on a sandbar, if you will. So this was my intro to the power of socialization, the power of not being alone. And I am not a gerontologist by training, by the way. By osmosis, yes. Actually, this experience taught me about the issue of this population, that they are aging. Their HIV issues are nominal. They're always there, but they're nominal. Their issues are about aging. So every staff person that I've hired since 2008 has been a gerontologist, not an HIV person. So, and I want to show you some data that brings us home. You don't have to read these numbers, but you have to do is follow this circle. These are changes that you see over age in the distribution of comorbidities in an HIV population. So what you see is that there are changes over time. They're significant, except the last one, depression. There's no change over time. Here's another cohort. Look at the same thing. These are changes in medication by age. Of course, it goes up over time. And yet, again, look at depression. It doesn't change. It stays 0. Here's another one. These are over 3 particular decades. And once again, we see the progression, which goes along with aging, and yet, if you look at the numbers for depression, they stay the same. something's wrong here. We know from our ROA studies, research on older adults with HIV, I'll talk a little bit more about that in a second, we know that there are high rates of depression in this population. So some people say, well, maybe you should be depressed. No, if anyone should be depressed. And yet, if you go back in the literature, you'll find that the rates of depression are the same today as they were in the 80s, the most difficult times of this epidemic. You might expect then that it should be reactive depression, but not here in the 2010. So, research on older adults, we launched this study. We decided that we would study 1,000 people on a variety of psychosocial issues. I had a great team of people from New York City who helped me put this together. We used all kinds of measures that were already published and validated, because we wouldn't have a control group, so we'd have comparative data. So this was ROA. I brought in Mark Brennan, who was my gerontologist and my right arm and more, to help write the book, which is data-driven. The book is now no longer available. If you want to read about this, you can. This was 2005, the data was collected. So I also want to mention that coming along the way, you encounter many researchers, as Stephen mentioned. And among them were economists. So we published this paper about the decomposition approach, the Owaka decomposition approach to HIV and older Hispanics in New York City. This made my hair hurt, little than I have. Economists go through all kinds of hoops statistically, and basically they're measuring human behavior. But nonetheless, I have 5 papers with economists, which actually amazes me because they all make my hair hurt. So we launched in 2015, 10 years after the original ROA study, we launched a multi-site study. This is being done in San Francisco, in Oakland. Actually, it's completed in Chicago, upstate New York, rural, and New York City. And I have a couple of people waiting in the wings. This is an N of 2,000. The survey was constructed with the advice of an advisory board. Again, looking at some very general psychosocial characteristics, including depression, but also self-report about medical status. Now, I can't go over all that data, okay? And we're just finishing the white papers. But imagine 2,000 people in 5 different locations who have different resources in each one of those locations. And I'm especially going to be interested in San Francisco and Oakland, which is a tale of 2 cities, sitting side by side with remarkably different economic situations and service repertoires. So one of the things that came out of doing ROA was that in New York City, suddenly about 3 women died in one building up in Harlem. And the woman who was in that building, let me go back for a second, was a city council member, and she made this observation, and she said, we're not doing anything about prevention in older adults. In fact, they traced the infection to one man, Romeo, if you will, in that building. So this is where advocacy came in place. I was taught how to get on City Hall steps, buttonhole people, to ask them for money so we could do some prevention work for older adults with HIV. Well, you know what? We got $1 million. In fact, we got $1 million a year for 5 years. It's gone down since then, but still substantial. And it wasn't just for us at ACRIA, but it was for other agencies as well. But we administered it. And it allowed us to mount these campaigns. Every year we mount a different campaign of prevention posters aimed at older adults with HIV. When we first did this in the bus shelter, we got these calls from people how horrified they were. You know, older adults had sex. They were horrified, even though they were older adults as well. So you can go to the website, Age is Not a Condom, and you can see these sites as well as a lot of information about how it is that older adults are at risk, and they are. So the primary risk for multimorbidity in older adults with HIV is a 3-letter word. So I give this a training weekly at GMHC, which sees 14,000 patients a year, half of whom are older 50. And I ask this question, multimorbidity is driven by what? 3-letter word, it's easy. HIV, okay? It's really, I'm sorry, age. My mistake, age. We're aging, we're all aging. I think it was Jeannie Singler who said to me, a geriatrician from Cornell who we work with, who's a collaborator, and she said, you know, I don't think people recognize the primary care physician and the patient, that they're both aging together and therefore don't notice that they're aging. But we are. In fact, we're all aging right now as I'm talking to you. So I want to just show you briefly before I finish some data that from the San Francisco cohort. This is a 200 person sample. And soon will come Oakland. You can go to our website and you'll find these. But there's a lot of data here, and this is a survey that takes about an hour to complete. It's meant to be very comprehensive and challenging. But this was new data, at least for us. The participants who reported childhood sexual abuse is considerable if you look at these numbers. And it is regardless of gender. Gender doesn't play a role in this at all. Males and females both experience these fairly high rates of childhood sexual abuse. If we look at the percentage of people who, I can't see that one. Okay, so these are the number of people meeting certain criteria when we tried to measure PTSD in this study. And once again, we saw, if I will, an average rate of 35%. That same number appears in Oakland, it appears in Chicago, and it appears in parts of New York City. These are very, very high rates of PTSD, and they are a challenge for treatment, if it exists at all, and it tells us a little bit about this population, the trauma that they have experienced, either because of HIV or before that. So why should we care about multimorbidity? Okay? And one of the things I learned a long time ago is you've got to be crass. You have to talk about money. So this study was done in California, or a summary of information, and it showed what does it cost to maintain a person with HIV as their number of comorbidities goes up. And I can't read those numbers right now. I've been putting lenses in today. But yeah, it goes up pretty high when you get about 5 and 6 comorbid conditions. This is what saps our healthcare system of money. And I don't mean that negatively, but it's a reality. And one of the things that we saw recently in an article that people with HIV who are aging are going into nursing long-term care facilities 10 years younger than they would be expected to go in. And they're being treated with certain drugs just to keep them calm. This is their lack of caregiving, which I showed you in the beginning, and the number of comorbid conditions they are confronting. This is not a good thing to do. This is not a humane thing to do. This is the last thing to do, and we shouldn't be doing it too early in life. People should be able to age in place. So, I have been advocating for ASOs to step up to the bat. Here we have an aging population. If you go into any ASO, you will not see many older adults. You'll see some, but not many. And GMHC, which absorbed ACRIA, has made a serious commitment to that. And these are the number of programs they have now, and they're growing for their patient population, which I am proud of and I'm proud to help with. This is what is needed. These folks need the wraparound services, socialization when it can be provided. It's the ASOs that were built on the backs of these older adults. That's why they exist. We owe them something. CVOs owe them as well. Not owe, but we have to provide services that are specific for them and that are friendly. When we opened one of these, the hub here in GMHC 2 years ago, I was sitting in the audience and there was a red ribbon cutting. And there were people in the audience who had not been back to the agency in 10 years at least. And they sat there and they said, you know, we felt abandoned. Probably one of the most horrible human feelings, to feel abandoned. You know, children get crazy when they feel abandoned. So do human beings. They feel they've been minimized and they are not cared about anymore by these very powerful agencies. Well, GMHC is trying to change that, as are others. I know an APLA is, San Francisco AIDS Foundation. The big ones can do this, but we have to encourage people to put money where it's needed, for the majority. Not all of it, some of it. I mentioned that I was part of the American Academy of HIV Medicine effort, and this was very, very beneficial to us. I always had Dick Havlock, he was here at my side, he's an ND, I'm not. And it was an extraordinary learning experience, and it is to this day. And it fed into this last project of mine. 2 weeks ago at the USCA conference, I launched the National Resource Center on HIV&Aging. This is a very, very comprehensive, easily accessible to the client site, where they can find out information about, you name it, comorbidity, psychosocial issues, special issues, women especially, and it will become a resource, I hope, for everyone across the country as we put on that map below. Anything that's going on in HIV and aging will be on that map. Just move the mouse over it and you'll see it. Thank you.